The Global Surgery Lab presents Temporary Abdominal Closure Techniques. The goals of this video are to identify indications of temporary abdominal closures, to describe two approaches to temporary abdominal closures, a negative pressure wound therapy technique and a patch technique, and to outline key post-management steps. The most common indications for temporary abdominal closures include as part of damage control surgeries in unstable patients, when concerned about abdominal compartment syndrome, as management of intra-abdominal sepsis, as part of a planned second look operation, and when unable to bring the edges of the fascia of the abdomen together due to anatomical reasons. Part 1. Negative pressure wound therapy. Here we will describe the steps to performing a temporary abdominal closure using negative pressure wound therapy. The general approach is as follows. 1. Apply a plastic protection layer to exposed viscera. 2. Pack the abdomen with soft spongy material. 3. Make 2 incisions 3 to 5 centimeters away from the primary incision. Insert drainage tubes. 4. Place an adhesive dressing on top of the primary incision to create an airtight seal over the open abdomen. 5. Connect drainage tubes to the negative pressure system. You will need a scalpel, Metzenbaum scissors, retractors, Kelly forceps, a urine drainage bag, soft spongy materials such as gauze, surgical towels, or a sponge, adhesive dressings, 2 drainage tubes, and a negative pressure vacuum. Remember to follow all safety protocols and best practices. To begin, a plastic bowel protection layer will be created to protect the viscera. In this video, plastic from a clean urine drainage bag was repurposed to cover the exposed viscera. Apply the plastic sheet to the open abdomen. Tuck the edges of the plastic under each side of the peritoneum. Next, pack the open abdomen with a soft spongy material. In this video, a surgical towel was used. The drainage system will now be created. Use a scalpel to make 2 small incisions, either superior to or lateral to the open abdomen. This video shows the superior location. For a longer primary incision, such as a trauma laparotomy, the lateral location should be chosen. Insert a drainage tube, such as a Jackson-Pratt drain, through each of these incisions using Kelly forceps. Tunnel the drainage tubes along the subcutaneous tissue. Lay the 2 drainage tubes over the surgical towels filling the abdomen. Cover the drainage tubes with another surgical towel. Next, create an airtight seal by applying an adhesive dressing, such as an iobin drape, to cover the wound and adjacent abdominal wall skin. Multiple adhesive dressings may be required to ensure the whole wound is covered. Connect each drainage tube to a vacuum. In this video, wall suction and syringes were used as examples of possible vacuum systems. Turn on the vacuum to ensure a negative pressure seal has been successfully created. Part 2. Patch technique. Here we will describe the steps to performing a temporary abdominal closure using a patch technique. The general approach is as follows. 1. Cut a sterilized plastic silo bag in an oval shape the size of the open wound. 2. Apply the sterilized plastic silo bag to cover the open abdomen. 3. Suture the sterile plastic bag to the skin at the edge of one side of the wound using monofilament sutures. 4. Repeat the suturing step on the other side of the open abdomen. You will need Metzenbaum scissors, a plastic silo bag, needle holders, forceps, monofilament sutures, and suture scissors. Remember to follow all safety protocols and best practices. To begin, obtain a sterilized plastic silo bag, also known as a Bogota bag. In this video, a urine drainage bag was used. Cut the bag using the Metzenbaum scissors to create a plastic sheet that will cover the exposed viscera. Apply the sterilized plastic bag to cover the entire open abdomen. Starting at the lower end of the wound, use monofilament sutures to stitch the plastic silo bag to the skin at the edge of the wound. Running sutures should be made to secure the plastic bag to the skin along the entire length of one side of the wound's edge. The sutures should be approximately 2 centimeters apart from each other. Repeat the same suturing steps as previously described on the other edge of the wound. However, this time start suturing at the upper end of the open abdomen and perform running sutures towards the lower end of the wound. Next steps. Post-op. Closely monitor the patient for abdominal compartment syndrome and fluid status. Change the dressings and examine the abdomen's contents every 1 to 3 days. A complete abdominal closure should be completed as soon as possible, and ideally within a week. In conclusion, a temporary abdominal closure is a technique which can help to reduce complications associated with an open abdomen, while waiting for it to be safe to perform an abdominal closure.